So, good evening to one and all present here today for the awareness webinar on cervical disc problems during COVID-19 and related pain management as well. So, we have our guest speaker for the day, Dr. Sherin Sarah Lysander from Chennai. She has been into pain management specialist for quite some time and been working with a couple of hospitals in Chennai. And she's here to give you a proper guidance on pain management and how during the work from home aspects, what all things we need to be taken care of. Over to you, Dr. Sheryl.
Yes. So can we start now or should we wait for 5 minutes?
We can start now.
Okay,
Slowly
fine.
let the participants join. Yeah.
Sure. Just 1 minute. My PPT is loading. Is it available now, the PPT?
Yes.
Yes. So good evening, everyone. So today I'm Dr. Shirin. So I have a pain clinic. So I'm a pain consultant there, Lysander Pain Care and Orthopedic Center. So welcome you all. So today I'm going to talk about cervical disc problems because this is something which, I'm seeing on a regular basis. Almost every day I see a lot of patients with complaints of neck pain. And I guess the trend is due to this work from home and all the related issues. So starting with it, so how to approach cervical disc problems, I would like to first throw light upon some bit of an anatomy. So we have a better understanding of what it is, and then we'll move on to the symptoms, the signs, and how we diagnose and how we prognosticate, and what is the, what are the interventions that we can do to relieve you of that pain. And then what are the tips and tricks to maintain spine health. So the whole presentation will revolve around these objectives. So let me start. 1 second. So coming to neck pain, so out of this is one study which was conducted globally. So they found out that out of 291 conditions that they studied, the global according to the global burden of disease in a 2010 study, neck pain ranked 4th highest in terms of disability. So from 1990 to 2010, the disability adjusted life years, that is how we say the percentage of neck pain people suffering from it as and a disability, that is the life this thing. So as a result of neck pain improved, it increased from 23.9 million in 1990 to 33.6 million. So that is about a 47% increase. That is, it has increased much more now to more than 60% of the people around the globe suffering from neck pain. So coming to anatomy, so first I want to talk a little bit of anatomy, not too much in depth, so we understand what we are dealing with, so everybody will be clear about the structures when I'm giving the talk. So coming to the anatomy, so first I would like to start that, this is your vertebral column. So you have 7 cervical vertebra, you have 12 thoracic vertebra, the 5 lumbar vertebra, and the sacral vertebra, which are 5 fused together. So in terms of, this is a sagittal section, or the, sideways, for better understanding of people who are not doctors here. So we are looking at the spine from the lateral aspect. So when you see that, so we have the two curves, the two main curves, which is the cervical lordosis and the lumbar lordosis. So when I say that, 1 second, I'll just get my pointer. So is the screen there now? Are you able to visualize the PPT? Yes. Okay. So coming to that, so as you can see in this model, so we have 7 cervical vertebrae, 12 thoracic, 5 lumbar, and the 5 fused sacral. So if you can just appreciate this curve, so this is a lordotic curve. So you have a cervical, so you have this lordosis in two places, that is one in the cervical region and one in the lumbar region. So these two regions are relatively mobile compared to the thoracic and the sacral regions. So the cervical vertebra is highly mobile, it allows flexion, extension, lateral rotation, and the lumbar vertebra as well. So whereas the thoracic is pretty much, not very mobile, it is almost like, very slight movements. Same applies to the sacral region. and roughly around 20 to 40 degrees is the lordotic curve. So coming to the regions of the spine, when we come to cervical spine, it is actually 7 vertebral bodies of the 7 bones, and there are 8 pairs of nerves. So then we divide it further into upper cervical and lower cervical, because the upper cervical, which is the C1 and the cervical 1 and the cervical 2. So these two vertebral bodies, they're slightly different compared to the lower cervical ones. And though there are 7 vertebral bodies, there are 8 pairs of nerves. So how these nerves come out of the transverse foramina is like this. So here it comes, so it all exists superiorly. So the nerve roots come superiorly to the pedicles in C1 to C7, and then the 8th nerve root exists inferiorly to the pedicle. I'm not going too much into the anatomy of pedicle and the whole vertebral body, assuming that all of us already know. So coming to the special characteristics of the cervical spine. So there are 3 peculiar things which are present in the cervical spine, distinguishing it from the lumbar vertebrae and the thoracic vertebrae. So the first and the foremost important thing, so maybe roughly I'll go through the anatomical parts in this. So this is a bifid vertebral body, a cervical vertebral body, which has a typical, this is a body of the vertebra. These are the transverse foramina. This transverse foramina on either side of the transverse process is present in the cervical vertebra, whereas if you look at the lumbar vertebra, it is not present. So again, then you have the anterior tubercle and the posterior tubercle, which again is a differentiating factor which is not present in the lumbar vertebra. And then you have the superior articular process, which articulates with the vertebral process, inferior articular process of the superior vertebra. And this is the vertebral arch, and this is the spinous process. This spinous process again is different in different cervical vertebra. So here it is bifid, whereas in the C7 vertebra, it's unifid. This is just to show you that how different it is from the lumbar vertebrae. And you have the transverse foramina. So this vertebral foramina again is triangular in the cervical. Then coming to the cervical vertebra, I would be explaining in a bit about the different vertebrae. So there is C1, C2, and C3 to C5 and the C7. But in particular, I want to mention about C1, C2, and C7 because they're slightly different when compared to the other lower cervical vertebrae as well. So coming to C1, as we all know, it is called the atlas. So basically it is ring shaped. It has an anterior arch and a posterior arch. So this, if you see, does not have the vertebral body. Of course, it has the transverse process on either side and the articular facets are present, and you have the lateral mass. So the main function, so what it forms is, so this is the structure, this is the vertebral body which articulates with the occiput. So it forms atlanto-occipital joint, which helps in more than 33 to 40% of your flexion is because of this atlanto-occipital joint. Then coming to the cervical vertebra or the C2, it has a very peculiar structure called the odontoid process or the dens, which is a bony prominence. So what happens is this bony prominence acts as a pivot. So you have a cervical vertebrae, that is you have C1 vertebra, which is the atlas, and below is the axis. So if I can get a better picture. So here I'm sure you can make out. So this is the odontoid process, and this is the C2 cervical vertebrae, and this is the C1. So this C2 goes inside and articulates. So it forms a pivot around which the atlas rotates and causes the rotation of the neck. So this structure also helps in identification when we are seeing an X-ray in the anteroposterior view. Then coming to the lower cervical vertebrae. So this forms a subaxial region that is below the atlas and the axis. So the disc, basically what we're talking about, and today's topic, everything is based on cervical disc. So the cervical disc in the cervical region starts from C2, C3 onwards. So in between C1 and C2, there's no disc. It is just 2 vertebrae together and forming the atlanto-occipital joint and the atlanto-axial joint, around which the neck movements, the rotation and all that happens, flexion and the rotation. So the intervertebral, so these are the vertebral bodies, and these are the intervertebral discs in between them, and this is the spinous process, and these are the facet joints here. So this is a rough anatomy of how the cervical spine looks. So Next, coming to the lower cervical vertebra, this is another peculiar thing which I would like to mention. Why this is of importance, I'll tell you. So if you can appreciate these two lateral projections on the articular pillars, so these are called the uncinate processes. So these uncinate processes, they form an articulating joint, which is known as the uncovertebral joint or the joint of Lashka. This joint of Lashka or the uncovertebral joint is carries a significant importance, because this is where most of the degenerative process takes place in case of a cervical degenerative disease. Next. So coming to the last vertebrae or the Vertebra Prominence C7, as we all know that whenever we are looking at an X-ray or we are counting the vertebral, the number, we want to count which vertebrae it is. So we always look for this, parrot beak appearance or the C7 prominent vertebra, which has a longer spinous process, and it is very evident. So when we see that, we know that we are at the level of the C7. So this C7 vertebra prominence, we can also palpate, when we are doing a procedure, and I think that C7 is the most prominent one. So it is longer, larger spinous process, and it is unifid. So this is another peculiar thing. So C3, C4, C5, C6. So all of this has a bifid spinous process, the one you see here, which I showed. So it has a bifid spinous process, that is C3 to C7. When you come downwards to the C7, so it becomes unifid. This is of importance, especially when we are using an ultrasound guidance to do a particular procedure, like, even a median branch block, if you're going to do ultrasound guided. So this carries significance, because we have to label the level at which level we are, to identify that it is based on the spinous process, whether it is unifid or bifid. So we first see the unifid spinous process of the C7. So from above upwards, we can count the level at which we are. So coming to the cervical spine, I want to talk about the axial section. So we are very clear on to how things go about. So this is a cervical disc axial cut, or the, transverse cut. So in that, if you see, this is your spinous process, this is the lateral mass, and this is your intervertebral disc. So if you can see the disc, it has two things. So the center one is the nucleus pulposus, and this is the annulus fibrosus. So usually these two structures, so basically the nucleus pulposus it is gel-like. So they form cushioning between your vertebral bodies to absorb. They basically act like shock absorbers. So coming to so whenever there is a pathological process which is happening in your disc because of cervical spondylosis, it is usually the nucleus pulposus which starts coming out. It's contained within the annulus. The annulus is multiple lamellar layers arranged in concentric circles. So when there is a tear or when there is degeneration, this nucleus pulposus comes out, and both of these, the nucleus pulposus and annulus fibrosis, if you see, their chemical structure is very slightly different. So when this comes out, the morphology and the disc as such changes. So these are the nerves. So this is the spinal cord, and then these are the nerves which are coming out through the transverse foramina. So this the similar section I have in the MRI. So this I'll probably go to later when we are talking about investigations for cervical spine. So yes, going next to the thing which is the most important part of this webinar. So how do we approach a patient with cervical pain? So of late, because of this work from home trend, I've been having a lot of patients with neck pain. So we'll go to how to deal with this neck pain. So initial management, then what are the red flags, and when do we need to consult a physician, and how to go on about it. So all of my talk will be based on these topics. So first, the type and pattern of the pain, the aggravating and the relieving factors, the occupational factors which play a major role, especially considering this, the current trend of working from home, and the use of smartphones and iPads for a longer duration. Then what are the red flags that we need to be aware of, so that we seek medical help early, and associated muscle spasms, and what are the different ways in which cervical disc pain can present as such. So coming to the pain pattern, so usually when you see the patients with cervical disc issues who come to me, which are specific, there can be non-specific neck pain because of various other reasons, but specific neck pain, or if the pain generator is either a disc or a facet joint that we are talking about. So most of the patients have a typical presentation. So this is why I wanted to show the distribution of the pain, how the patient presents to you. So whenever there's a disc compression at the level of C2, C3 or C3, C4, you can see this the picture where, this particular region, that is from the occiput, the below downwards, the lateral side of the neck and the posterior aspect of neck, patients complain of pain. Once it comes to the lower cervical vertebrae, or the lower cervical vertebral discs are involved, or there's degeneration of the lower cervical disc, they usually present with pain more of in the shoulder, the arm, and the upper back. So this upper back pain is something which you need to really look into, because a lot of times we think that the upper back pain is because of all other reasons, like a muscle spasm. Yes, a muscle spasm due to a cervical disc is possible, but at the same time it goes undiagnosed. People start treating the particular region, that is okay, they have an upper back pain, so they just keep treating them with muscle relaxants and analgesics and NSAIDs, thinking that it is something related to the upper back. So most often it is the cervical disc which is very notorious for causing upper back pain. So as you can see, if the lower cervical, that is, even if most commonly what kind of disc we see is usually the C5, C6 and C6, C7. So I have a lot of patients who present to me with upper back pain predominantly more than neck pain. Very often we see there's no neck pain, there's usually an upper back pain, or they say a shoulder pain or a pain which is radiating to the arm. So that I will be talking about later, that which is a different entity again. So this is how they present. So upper back pain, always remember, never forget cervical disc. Initial management can be conservative, but always keep in mind that there can be a cervical disc problem which needs to be sorted or which needs attention. The other very common pain generator in your cervical neck or the cervical disc problem or the neck pain as such, the specific or the non-specific neck pain, whichever it may be, is the facet joint. Facet joints are very, very notorious to cause pain. So when the facet joint pain, and on the facet joint pain and the disc pain is usually slightly different in presentation. So when you see the facet joint pain, so the facet joints are in between, on either side more. So the pain is more laterally located. So when you have a discogenic pain, it is more toward the center, and if there's nerve compression, it starts radiating. But whereas if it is going to be a facet pain, it is more on the posterolateral aspect, on the lateral side. The patient usually localizes, like, this particular region of the neck is paining, this particular region of the neck is paining. Exact, sometimes it is more like exact, and when you take an MRI, you'd be surprised that it is the exact same region which the patient was pointing to. So coming to that, yes, so you can see here how the distribution is. It is more or like closely similar, because sometimes, usually what happens is the disc and the facet at the same time they have pain. So that can be a little tricky, but usually we'll be able to differentiate. So yes, so coming to the and then coming to how the pain is. So a disc pain, if you see the nature of the pain, so usually it is a dull, aching, constant pain. It keeps it is not like either it just comes for a few minutes in probably in a position which you've changed, so then it slowly progresses. Whereas a facet pain, sometimes it can be a little more sharper than the dull, aching kind of pain, and it is more towards the lateral and more in the neck region. And facet pain as such, you will not have any radiating pain to the arm. More often that is in the disc, something related to the disc only. So coming to the red flag signs, before I go to the other symptoms, I want to emphasize on the red flags, because this is very, very, very crucial, and patient needs immediate medical help, and we have to sort these issues before we go to other things. So red flag signs, always beware. So what are the red flag signs? So these are 5 things. It applies even to the lumbar vertebrae. So you have neurological. If there is any neurological involvement, that is, if you feel there is a decompressive myelopathy, there is a demyelinating process which is happening. So always, if you suspect these things, go directly for an MRI. Don't put the patient on, just give them analgesics or muscle relaxants and send them home, because the more time or the delay really matters. Then coming to other causes. So other red flags, infection is highly notorious, especially infection of the spine can be dangerous. So we have to look for, always when a patient comes to you with neck pain, all these things have to be ruled out then and there in the OP OPD. So if they have fever, if they exhibit any signs of meningism, or if they are on history of immunosuppression, that is they've been taking some immunosuppressant drugs post transplant, or for rheumatoid arthritis they've been on immunomodulators and all that. There are these are patients who are at high risk of infection. So always keep in mind that there can be an infection. The pain could be related, the neck pain could be related to the infection, and always rule out. So then in that case, you will require an X-ray and an MRI as well, but an MRI is more specific. So then coming to a fracture, so never ever miss a fracture. So what I usually do is, people coming with the neck pain to me in my OPD, so initial investigation, I always take an X-ray, be it cervical spine or a lumbar spine, or any joint pain. So just to make sure that we are not missing out a fracture. A fracture of the vertebral body is very dangerous. So or even an osteoporotic fracture. So trauma, yes, definitely the patient is going to give you a history of trauma. In that case, you need to be very this thing in diagnosing that, okay, there could be a fracture. So we are all very aware that, okay, if there is a trauma, we'll definitely want to rule out fractures. But when a patient comes with neck pain, it is very normal to miss out on a fracture by not taking an X-ray. So never hesitate to take an X-ray. So better always take an initial X-ray just to document that there is no fracture. And CT, if we feel that in the X-ray we are not able to clearly appreciate a fracture, then we can always go for a CT. Then tumor. So signs of carcinoma, yes, we all know. If patient gives you a particular history of along with neck pain, patient has history of significant weight loss of appetite, he's also having some other symptoms, or some symptoms related to involvement of other organs or other systems, then always evaluate further. Then inflammatory conditions, as I said before, rheumatoid arthritis, giant cell arteritis. Though I treat some bit of rheumatology conditions, I always get a rheumatologist opinion because they're expert in that field. So then coming to the next condition. So what are the clinical conditions that can affect your spine? This is just a general view of what all can be there apart from cervical disc issues. So you have, starting with so you have bone, muscle, the disc, and certain other referred pain and referred conditions. So coming from the bone, it is usually a vertebral body degeneration. So what I get is, disc osteophyte complex. That is what they say. So I get referrals in the name of disc osteophyte complexes. So here I have a picture just to show you how it looks. So if you see, this is the vertebral body, this is the spinous process, these are the transverse process, these are the nerve roots, which are spinal nerves, which are exiting, and this is the intervertebral disc. So this is a normal, healthy vertebrae. So looking at how the degenerated spine looks, so you can see this, the disc height as such is being reduced here. There is a disc osteophyte complex, there is disc degeneration. So all of these things can compress your affecting nerve, exiting nerve. Then coming to the muscle, in a patient who comes with neck pain, spasms are very common, but most often, as I said, muscle spasms could be related to cervical disc or cervical spondylosis. And then the nerve pain or the radiculopathy, I'll be talking in detail about it a little later. Then headaches are also a part of the cervical disc spectrum. So those are called cervicogenic headaches. So I'll be talking a bit more on the cervicogenic headaches in the coming slides. And referred pain. Referred pain is again more related to cervicogenic headache. So coming to the cervical facet pain, as I said, so this is the cervical facet joint. You can see this is the cervical vertebral body. This is the cervical disc. So this is your spinous process, and this is where is your facet joint. So when your facet joint is inflamed or degenerated, so you can have a neck pain which is more sharp and not a sharp shooting pain, but a sharp blunt pain which can be there, but there is no radiculopathy as such, and there can also be a headache. And more often when there is a facet pain, they have a limited range of motion, that is the neck movements are affected because it's more painful. Then so coming to the next thing, that is the cervical radiculopathy. So cervical radiculopathy, as I said, it is very different. It is a sharp tingling pain radiating to the arms. It is usually because of a pinched nerve. So what happens usually is, just one second. Yes. So what happens usually, sorry, yes. So cervical radiculopathy, as you can see, so whenever there is a, there's a cervical vertebra, there are two vertebral bodies, there is a disc in between, and the nerve roots are exiting on either side. So what happens is, at this particular time, as I showed you, so if you can see this axial section, what happens is, this particular region, there's a tear or there's some degeneration happening. So this nucleus pulposus starts coming out and herniating, and the disc comes out. So once the disc comes out, there's no space. So what happens is, it causes compression of the nerve. So that compression at any level. So for instance, there is a C5, C6 intervertebral disc degeneration. So what happens is, it comes and compresses the C6 nerve root, and you have pain radiating in the entire dermatomal level at which the nerve root is supplying. So in all those regions, you can have radiating pain. So it comes out, there is a chemical change which is happening. So what usually happens is, whenever there's an intervertebral disc problem happening, so, or a spondylitis, the whole structure of the nerve itself is changed. So that causes at the biochemical level, the change happens, which leads to pain. So yes, I will go back to the radicular pain. So so patients with a severe disc disease usually come with cervical radiculopathy. As I said, pain, numbness. So if they have pain and a bit of numbness and tingling, it is okay. You can manage them conservatively, and then you can put them on interventional procedures. Whereas going to the red flag signs, same patient with radiculopathy but having a lot of tingling, paresthesia, and having loss of sensation, then definitely they need surgery. So beware of the red flag signs and always pick it out in the OPD itself, so we don't miss out those important things. So these are other tests which can be used to assess cervical disc. So there's a Spurling test, which is like you actually, it is like reproducing the compression caused by the cervical disc. So you compress on the side where you're having the radiculopathy and see if the patient is having severe pain. So most often these tests, yes, you can do the Spurling test and the shoulder abduction test and, assess the pain, but usually you will be able to elicit from the history itself that, the cervical disc involvement is definitely there. Then coming to cervical muscle spasm, which I talked about. So most often the patients which I get in my OPD complain of pain in the upper back. So when you just palpate and see, the rhomboid muscles are there will be severe rhomboid spasm. The muscle literally feels like stone. And apart from that, they also have some trigger points, which are, swellings in the musculotendinous junctions. So, a ball rotating that the patient will tell you exactly where it is paining. So these are all part of the cervical disease, disc spectrum only. So so I've just mentioned the three common muscles which are involved in cervical disc, pertaining more to the lower cervical disc. So it is the rhomboids, the trapezius, and the levator scapulae. So usually the rhomboids, these muscles are usually, and the trapezius. So these two are more often, the most common spasm which we see in cervical disc disease is rhomboids and the trapezius. So what happens is, sometimes when patients go to, certain other physicians, so they think, not in terms of cervical disc, and the disc is usually missed out, and it takes a very long time for them to come around and, diagnose this. So it is better always to keep in mind that somebody coming with a cervical muscle with a upper back muscle spasm, to keep in mind that yes, they can have a cervical disc issue. So coming to the cervicogenic headache, as I was saying, so headache, yes, you have to differentiate the cervicogenic headache from migraine headache. They have very different characteristics. So cervicogenic headache occurs most commonly in the occipital region, the frontoparietal region, whereas your migraine headaches, usually it is very close. So, often physicians get confused between migraines and between cervicogenic headaches. So there's no point in treating the migraine when it is actually a cervical disc which is causing a headache. So so the differentiating factor is a few symptoms actually. If you see a cervicogenic headache, it is more in the occipital region. It will be there it can be there for few hours or few days, or if the slightly because of a positional change, it can be there, and it is usually a dull aching pain. Whereas migraine, it is more episodic. They have an aura, and it is more throbbing and pulsating, and it is unilateral, but there is a shift. Whereas cervicogenic headache usually is unilateral but does not shift so easily like a migraine. So why does this cervicogenic headache occur? So there is a nerve apart from the greater occipital and the lesser occipital nerve. We also have a nerve which is a third occipital nerve. So this third occipital nerve, if you see, it is a nerve. It is a continuation of the nerve from the third dorsal ramus. So this particular nerve supplies the facet joints in that region. So that is the reason it is causing pain. So the pain generation is because of so whenever there is a C2, C3 disc involved, or C2, C3, the facet is involved in that particular patients, you'll have a presence of cervicogenic headaches. So for cervicogenic headaches, we usually do a diagnostic block. So with the local anesthetic and see if we do a landmark technique. So to see if the patient is responding. So if the pain disappears with the block, it means that they are having a cervicogenic headache. So it is more of a diagnostic, and you can go ahead and treat the disc disease, and then you can also do an RF ablation of the third occipital nerve. So coming on to how you investigate or how you approach a patient with a disc pain after you've gone through the history, you've gone through the symptoms, the signs, and also their medical history and their posture, their work. So yes, coming to that, occupational factors play a major role. So we have to always find out, because there are patients who come to you, they always come with, they don't tell you what kind of, the posture they maintain. It is very essential to know that, because if they continue maintaining that wrong posture, or there is an occupational hazard, or it's because of that the disc issue is getting exaggerated. So we have to be wary of that, and we have to we have to counsel the patient regarding that, because if that is the factor which is causing or worsening the disc, then that has to be looked into. So coming on to the investigations part, so usually in my clinic or in my practice, what I do is I do a complete blood count. I do an erythrocyte segmentation rate and sedimentation rate, C-reactive protein this thing, and then levels, CRP levels. I do an RFT, renal function test. I'll do a sugar test, or RA factor, uric acid, and vitamin D and B12. Yes, you can ask me that why I'm doing all of these things, because I do a complete blood count just to rule out that I'm not dealing with any infection here. ESR, CRP, of course, RA factors to rule out rheumatoid arthritis, and uric acid, because gouty arthritis again is a major issue. Then apart from that, the vitamin D and B12 levels, because more often I see our Indian population pretty much on actually there was a recent study which was conducted which shows that almost 90% of our Indian population is suffering from vitamin D deficiency, and they definitely need treatment, supplementation, because because of the melanin in our skin. So we don't even yes, we can have sunlight exposure. As we all know, the dermal synthesis plays a vital role in vitamin D, but even then maybe 20 to 30% of the vitamin D synthesis can be triggered by that, but usually we need supplementation. So the cutoff level is like 20. Anything less than 10, I usually have patients who complain of a lot of myalgia and lot of pain. So we need to, sort that as well. It can be a generalized myalgia, but sometimes it can also be specific to certain regions, which we have to be careful. Yes, cervical disc is there, but if we are not correcting these other factors, then that is also going to pose a problem. Next, so coming to from the investigations, I want to talk a little on the cervical spine X-ray and cervical spine MRI. So cervical spine X-ray, why? As I said, any patient who comes to me, so I do a cervical spine X-ray so that I rule out if there is any fracture, to rule out the red flags, and so I know what I'm doing, and there is no there is no cause, there's no fracture which is causing the pain which needs immediate medical attention. So just roughly about the X-ray, this is the anteroposterior view, this is the lateral view, as we can see. So just a bit on how to see a cervical spine X-ray. So this is how to count the vertebrae. So as you can see, this is the vertebra prominence, this is the C7 vertebral body. So C7 vertebral body, these are the facets over here. If you can see, these are the facet joints. So C7, C6, C5, so upwards, and this particular thing is your C2 vertebrae and C2, and this is the, if you can appreciate this particular structure, it looks like a lingam actually. So that is the odontoid process of the dens. And so in a cervical spine X-ray, we look for any fractures, we look for reduced disc height, and also we see if there is any, also the lumbar lordosis we can appreciate with that. And AP X-ray, usually we just see the, uncinate processes over here, the uncovertebral joints, if there is any degeneration in that. So these are the spinous processes. And also this is this is your C7 again here. Then coming to the cervical spine MRI. So when is MRI necessary? So what I usually do is a patient coming with cervical disc issue, or I've diagnosed it, or they say that yes, they've already been having cervical neck pain for quite a long time. So initially I take an X-ray, as I said, to rule out the red flags, to see if there's any fracture. I put them on conservative management with the medication. So I'll go on to the pharmacotherapy a little later when I come to the management part. So then if the patient is not settling down with all of this, it is worth the shot to ask them to get an MRI, because very often we find that they will definitely have 2-3 cervical discs if the pain is not getting controlled with the initial treatment that you give. And it's better to be safe, because if there is progression of the disease and you just keep treating them symptomatically, then medical legal, so it could be a problem. So coming to cervical spine MRI, so also roughly again the structures here, these are your vertebral bodies. So as you can see, this again the same structure, the odontoid process we identify here, and then these are the intervertebral discs in between this. You can appreciate the disc more better in the lumbar vertebrae compared to this, because these are much smaller. So you can even see the nucleus pulposus and annulus fibrosus there very clearly. So coming to the so in this particular region, so this is your spinal cord, this is your spinal fluid. So this is the ligamentum flavum around it. So here, if we see, so can you see the small indentations over here? So this is nothing but your intervertebral disc, which has, it is not, the disc is not contained, it is going and causing compressive myelopathy here. So this is what we need to look for. If we cannot, go through the entire, yes, of course, the report is there, but I always go by the image because I want to see where exactly the problem is and where exactly the compression lies. So, and which are the discs which are involved. So it is worth the effort to actually see where it is getting compressed. So if you can see, this is C2, this is C3. So C3, C4, C5, C6, C6, C7. So these are the discs involved. And you can see that you can just make out, no, the continuity is actually gone in these places. If you can see here, it is normal. Again, here it is normal, but in these 3 particular regions, there is a compression. The same thing in the axial section. So I'll just point out the structures. So this is the vertebral body. This is your disc. And this is your vertebral artery here, and usually the nerve is exiting from this side. And if you see in the lumbar, it is more prominent, to see the so this is actually the ligamentum flavum, this V-shaped structure which you see. So usually this is almost a normal cervical spine, the axial cut which I have shown, like similar to how I showed a picture of the axial cut. So there will be some disc which is herniating and which is compressing or pinching the nerve. Next, so coming to what other additional investigations I might do. So this less often that we do, because more often, when we see a cervical disc, mostly from the MRI itself, we will be able to make out, and we've done the investigations, we've ruled out any kind of flag signs, arthritis and all those things. So, and arthritis, infection, fracture, we've ruled out all of that. So we've taken the cervical spine MRI, and the MRI has also shown, okay, there is a disc involvement, there's a disc osteophyte complex which is there, which is compressing the nerve and causing compressive myelopathy. But yet in some certain scenarios, we might have to do a nerve conduction study or an electromyography. Why it is done is, you have to just, because sometimes the patient might not have a neck pain, they might have radiculopathy, but they will go like the pain is not radiating from this side. If it is radiating, then it is very clear from the symptom itself that it is a cervical disc pain, which is a compressive myelopathy, which is causing radiculopathy and causing the pain. In some scenarios, the pain can be only in the arm. So only when it is generated only from the arm, then we have to be a little careful. And this group of patients might need a nerve conduction study. So this nerve conduction study, what it does is it differentiates whether it is a lesion from the cervical root or it is due to a peripheral entrapment neuropathy. Very often a lot of peripheral nerves can get entrapped, and it can cause a similar pain in the hand, which is not essentially from the cervical disc. So just a rough idea. So as we all know, nerve conduction studies, so they stimulate the nerve, they record the impulses which the nerve and the muscle, they control it, and they see the pattern at which pattern to see if there is any nerve compression which is happening because of a peripheral nerve entrapment, basically. So going on to what are the treatment options available. So why I have put reassurance is most of the patients, even with mild disc disease, as soon as you tell them, okay, it is a cervical disc spondylosis, they sort of start panicking. So reassurance is the key for everything. And even for future, if there is worsening, if you need to do any intervention, so if they are very confident in you, so and reassured, they also oblige, okay, they say, okay, the treatment is going right. And patient education is very important, because they need to know that if there is any occupational hazard, if there is any thing pertaining to their lifestyle which is causing this disc issue, then that needs to be addressed. So we start always with patient education and lifestyle changes, how they can modify certain things, because these things might sound simple, but they are very important and go a long way in managing cervical disc problems. Then coming to pharmacotherapy and of course the interventions. So coming to lifestyle changes for cervical disc problems. So first thing is the posture correction. So most often patients are, you don't realize that you're slouching, or your neck position, your neck is not in the neutral position. So over time, when this particular posture is being, there for a very long time, you're maintaining this, and not in your neck is not in a neutral position. So definitely there are higher chances, or there's increased risk of cervical disc problems. And ergonomics play a vital role, because nowadays with the work from home trend, as I said, in offices usually what they do is, I mean, the table and the chair, everything is perfect, and in a way that it does not, your spine is in the neutral position, and the lordotic curve, everything is maintained, and your lumbar support is there. So when it comes to working from home, so we take it for granted, we don't sit on the bed and work, or just lie down and work. So those things need to be avoided, because recently there is a very high increase in cervical disc problems is ever since the lockdown started. So that is very important. So if you can see your the way you sit, so this is how you're supposed to sit on a chair, or if you're working, so that your lumbar, there should be a lumbar support, your neck needs to be in the neutral position, straight, not extend, not too much extension or not too much flexion, and your eye level and your screen level should be at the same level. And then your arms, so this is another problem which I've been encountering a lot of carpal tunnel syndromes of late, and it is all due to the repetitive motion with the mouse that they do, but without resting the hand. The wrist is just in air, and then they keep operating the mouse, and they get this carpal tunnel syndrome. Very commonly we are seeing these days. So this is how you need to maintain a posture while working from home. So get yourself a proper chair and a table. Yes. So coming to diet, yes, vitamin D rich diet and supplements are necessary, because most often we are all nutritionally deficient. So don't overdo the supplements, but whenever it is necessary, please do take it. A short course will do. Then coming to exercise. So posture correction, yes, I forgot to mention this. So this is a posture corrector which you can use. Most often patients tell me that they are not able to maintain, even though they want to, unintentionally, just while working or while reading, they forget it, and that there's a change in posture. So in those conditions, so in that way, so posture corrector helps you, so you know that you have to keep your back straight. So a couple of patients do well with these posture correctors. And then this is a mattress. So usually the soft mattress is not something which you're supposed to use. Yes, I'm aware that it is very uncomfortable, but a very soft mattress in which you sink in, it does not, as I said, the sagittal planes or the curves of the spine, how it is maintained. So if so that all of that cervical lordosis, the lumbar lordosis, and the whole spine, the shape of your spine changes when you have a bed which is too soft and you sink in. So you need a mattress which is firm yet comfortable, and you need a pillow. Usually, patients with cervical disc, I advise them to use this pillow for some time, or just fold 2 sheets and keep it, and not use a pillow. A 3 to 4 inches pillow should do good. Not, a lot of them use these 2 pillows, and these are all actually, they don't maintain your spine in a neutral position, very hazardous for your cervical spine. Coming to exercises, I'll be going and talking a little elaborate on that, because a regular exercise regime goes a long way in maintaining your spine health, not just your cervical spine, your lumbar spine as well. So yes, going to a bit of the pharmacotherapy. So pharmacotherapy usually for patients. So I start with, going by the WHO ladder of pain. So I usually follow that, and it seems to, work really well for my patients. So first I start with, paracetamol, which is, and it's more safer, before assessing. So yeah, so coming to why I wanted renal function test. So renal function test is essential because a lot of times, especially in these times, what I'm seeing is the patients are on Siddha medicines and alternative therapy, and you do not realize that they've been taking it, and then you just start them on NSAIDs, and if the renal function is altered, then again, we are in a fix. So it's better to go ahead and do the renal function test and then start them on NSAIDs, because it is very, very dangerous. And this dose of NSAID can trigger a renal injury. So we have to be a little cautious. So I start with paracetamol. I add some weak opioids. Tramadol I use very little, rarely, because tramadol is notorious for causing nausea. A lot of my patients don't tolerate it, so I go for NSAIDs. NSAIDs we can use, the COX inhibitors we can use, and muscle relaxants. I usually use the thiocolchicoside, or the stolperazone or tizanidine. And there's a last one, which is baclofen. Baclofen usually is not necessary for the cervical disc patients who have mild to moderate disease. Baclofen is more of for a spasticity related issues. So it is mostly commonly I put my patients on tolperazone, and they do really well. A short course of muscle relaxants. Actually, usually pharmacotherapy is mainly to control their pain, the acute pain which they get. So I put them on medicines for 3 to 5 days. On the 5th day, I start them on physiotherapy. Physiotherapy, in the sense, it's just not just modalities. So modalities, maybe the initial stage when they have severe pain, you can use a modality to, reduce the pain, and then teach them exercise, because the exercise and the rehabilitation part is what plays a major role even in severe disc disease. And apart from these medications to control pain, we also give neuropathic pain medication, because as I said, when when there is a cervical disc which is causing compressive myelopathy, the nerve morphology changes, and there is a radiculopathy which is happening. So for that, neuropathic medications are essential. So I usually put them on gabapentin, or gabapentin, and this thing, methylcobalamin, and all those supplements, I add them. And vitamin D, of course, usually I start them off, but some then, or I see the reports, usually vitamin D deficiency is very common these days, so better to correct that as well. So then after pharmacotherapy, coming to physiotherapy. So physiotherapy, as I said, is not only modalities. Modalities are only to control your pain. So maybe an IFT, an interferential therapy, or an ultrasound therapy for the muscle spasms initially, then later, but usually I start, so modalities just for the pain part, which I control for 2-3 days. And then I put them on a regular exercise regime, the cervical spine stretch and strengthening exercises. So on a regular basis, I tell them, like, morning 20 minutes and evening 20 minutes at least for 2 to 3 months, because that is very, very essential. I've seen patients recover beautifully with the ones with cervical disc problems, like mild to moderate disease, just with good exercise regime. Then coming to, so this is something which I didn't talk about when I spoke about muscle spasms. So apart from that, as I said, they can also have trigger points. Apart from the spasm in the trapezius, the spasm in the rhomboids, so the myofascial pain syndromes are also common to occur along with cervical disc. So myofascial pain syndromes, they occur in the musculotendinous regions, and they are like, they'll be like a ball, rotating. So patients actually typically tell, so I have pain in this particular region and it is rotating. So what we do for these patients is usually, yes, apart from the posture correction and the sorting the cervical issue, if the pain is too severe, I also give them trigger point injections. So what we do is, in these trigger point injections, we exact pain is located, like we ask the patient to locate the pain, and we can either do a dry needling, just take a needle and break the points, break the trigger point, or what you can do is you can use 1%. So I usually use 1% lignocaine. So you can do this procedure on an OPD basis, as because they sometimes the pain generation from this myofascial trigger points is very severe, so patients don't tolerate. So in those kind of patients, I do a trigger point release. So manual release is usually, my physiotherapist does it, and it helps, but not always, because it is also a little bit tricky. Trigger point injections, apart from injecting a local anesthetic, sometimes, yes, I do use a small dose of a steroid, depometrol, which I methylprednisolone, very small dose, actually around, like 3 to 5 mg I use, and I inject it. Yes, you can ask me if myonecrosis can happen, but the myonecrosis which happens with this small steroid is very negligible, and it is not going to cause any further damage, because I inject basically 1% lignocaine, around 1 to 1.5 ml per trigger point. Just dry needle it for some time and then inject. Usually there'll be a reflex as soon as I touch the trigger point, the exact region. So I inject it there, either ultrasound guided, or I do it in this thing landmark. I mean, based on where the patient has it. And one more option which is there is the Botox, which we most common use. It is more reserved for people with myofascial pain syndromes who have trigger points in multiple regions, and they have which are not, they are recurrent, and they don't go away. So in those kind of patients, Botox has a really good effect. So I have tried in 1 or 2 patients who have the whole upper back, and lower back, they have myofascial trigger points. So in those kind of patients, Botox helps. Then coming to cervical, so cervical interventions in the spine, which I commonly do, and these interventions usually are needed when pharmacotherapy, physiotherapy, and conservative management, still has not relieved the pain. So in those kind of patients, unless they have red flags, if they have red flags and if they need surgery, they are referred for surgery. If the only problem is the disc is mild to moderate and they need pain control, and pain control, so that they can do the rehabilitation in a more better way. In that scenario, I do certain interventions. So today I'll be describing mostly about the 2 common interventions which I do. So one is the cervical epidural, and the other is a median branch block. So cervical epidural, so most commonly, so if you see lumbar epidural injections, so selective nerve root injections, we are based on the anatomy. So we do it through the transforaminal route, whereas cervical, we do it in the interlaminar. So why the interlaminar is because a transforaminal is banned, because it is very close to the vertebral artery and carries a very high risk of puncture. So it is better to do the interlaminar way. So what we do is, at the level, so as we know, the cord is actually very thick, the spinal cord is very thick in the cervical region, so it is a little risky. It can cause even paraplegia if you're going to blindly go in. So usually I'm more of a fluoroscopic person, so I do fluoroscopic guided procedures. So cervical epidural under fluoroscopic guidance I do. So which level? So either I do a C7 T1 level, or I even do a T1 T2 level. If the disc is much higher, like say I'm entering from T1 to T2 level, but the disc is at C4 C5, no issues. I can always thread in a catheter and I can give the drug there. So cervical epidural patients, most commonly the indication is patient with severe cervical radiculopathy not controlled with pharmacotherapy. So in those kind of patients, we do this procedure. So it is more of like a daycare procedure. Patient is of course fasted, because we might have to give them a mild sedation to tolerate the procedure. So patient is put in the supine position. We can use a spine board, but I normally the C-arm orientation is based on how the patient is, so we do it that way. And what we do is, at the level of C71 or C81, so I use an 18 gauge epidural kit, which is a 2 Hoy's needle. And most often, if it is a much lower level, then I can inject the dye and see if it is okay to give the drug in that level. If I see the spread is adequate enough, if it's a C5, C6 or a C6, C7, it is pretty close to the C70 term. So the drug ascends up well. But in cases of higher discs, what happens is it does not go. So in that scenarios, I use I thread a catheter and then I give the drug. So what a drug I most commonly use is it is a combination of a local anesthetic. That is, I use preservative-free lignocaine, very essential, because as we are dealing with the very close to the spinal cord, very close to the subarachnoid space, so where chances of high spinal is possible. And since that is possible, since the breach of subarachnoid space is possible, it is better to always use preservative-free. For that instance, even for local, which I give before doing the procedure, even for local anesthesia, I use 1% preservative-free lignocaine, so that way we are more safer. So once we, along with that, I use a deposteroid, which is mostly methylprednisolone, and sometimes I use triamcinolone, but methylprednisolone is relatively better. So around like 20 mg to 30 mg I use. So yes, this so just rough fluoroscopic anatomy. This is actually an AP view. After usually start with an oblique view, and then I go to an AP and the lateral view to assess the depth of my needle insertion. And this is actually after inserting the needle and after I've gone. So once I've reached the posterior this thing, I start the same technique how we use for lumbar epidural, interlaminar epidural for surgeries. The same way this procedure is done. So once we get some needle stability, and usually it's fluoro guided, so I can see which structures I'm passing through. So in the lateral view, I assess the depth and I see, and then I go ahead and I inject I don't have a video of the procedure. So we do that, and then we go ahead, and then after I've reached the space, so we use the same loss of resistance technique. One thing we have to be one thing which is different is, usually when we say cervical epidural, everybody might think that the depth of the usually the 2-wise needle is 8 centimeter. So if it is a cervical this thing, so people might get confused that, oh no, we might reach the spinal cord very early in the subarachnoid space. No, that is not how it is. Actually, if you look at it, it's much more deeper in terms of interlaminar approach itself. If you see, almost sometimes I've had even almost like 7 to 8 centimeters fully inside in obese patients. So it is not the length which is going to assess, but yes, we have to be careful. Since it is fluoro guided, we are assured of that we are not injuring the spinal cord. So coming the next picture probably will have, yeah. Yes, so this is a cervical epidural, which I did for one patient with C6, C7 radiculopathy. So if you can just see, this is actually post-injection of the dye. So we use a non-ionic contrast. So to see if we are, whether we are inside any vessel, or whether we are inside the subarachnoid space, or if we are in the epidural space. So what happens usually is, so now I'm in the epidural space. You can see here all the cervical nerve roots which are exiting. So what I usually do is, so in this procedure, one problem is when usually what happens is the drug spread, usually happens towards, it goes more downwards. So in that scenario, the troubleshoot is you just, turn the needle, because as we know, the bevel in the 2-wise needle, it has a slight angulation. So you angulate it upwards and you thread the catheter up. So then you can see for the drug spread, see for the nerve roots which are exiting, and proceed further and then give the drug. So this is the interlaminar approach of cervical epidural. It is a very rewarding procedure. Patients have very good pain relief immediately and post-op. And over the period of 1 to 2 weeks, they have almost like 70 to 80% of pain relief, which I have noticed. And post this cervical epidural, within like 5 to 7 days, I start my patients on physiotherapy, that is exercises, because rehabilitation is the key. So if they are going to just once they are relieved of pain, it does not mean that the disc problem has gone, because that is the understanding of common layman patients. So that is very essential. We have to address that. So we have to make sure we tell the patients ahead that it is important to continue your exercises. Usually I advise the regimen for 3 to 6 months on a regular basis, so that the disease does not progress, or there's no worsening. Maintaining posture, doing this exercise, all of that is very important. Then the next procedure which I commonly do is a cervical median branch block. So as I said, facet joints are very, very notorious apart from causing pain as major pain generators in lumbar disc disease. So lumbar disc disease very commonly we see. And in lumbar disc, what is the difference is in lumbar facet joint, one thing is we do a median branch block. As you know, the facet joint is supplied by the median branch. So it is supplied by the one nerve above and below. So you have to block both the levels. So similarly, so one difference again in the anatomical point of view is in your cervical region, the facet joints which are present, they do not have a good articular capsule like how it is present in the lumbar region. If you see in the lumbar region, we also, apart from doing the median, first we do a diagnostic facet block and then we do an RF, but prior we also do an intra-articular, I mean, we inside the facet joint, we give the injection. That is, we deposit the steroid. So that similar thing here, it is not very this thing because, you know, this does not have, it lacks a capsule, the cervical facet. So in cervical facet, we usually do a cervical median branch block. As I said, we do a diagnostic injection with the, 1% lignocaine to find out if that is the pain generator. And then we go ahead and do an RF ablation. So these are the two common procedures which we do, and these are very rewarding. Patients feel, at least 70 to 80% pain free. But then again, it depends on the severity of the disease and how symptomatic the patient is. And as I said, rehabilitation post this procedure is very essential. So this is a study conducted by one of the pioneers in pain medicine, Manchikanti. So so what they have found out in this study is the cervical medial branch block in chronic neck pain has almost like they have shown increase pain relief of 40 to 60% in most of the patients which have got the procedure done. So it is very rewarding in those terms. So coming to the end of my presentation, so how do you approach a patient with cervical disc problem? As always, history, the symptoms are very essential. Symptoms and signs play a very vital role in diagnosis. Then physical examination. So you examine for, the radiculopathy, facet, what type of pain, and then the symptoms and then you go to the signs, examine the patient. If they have any muscle spasm, check the rhomboids, check the trapezius, and then assess, and then try the patient first. So the first initial line of management is pharmacotherapy with medicines, as I said, NSAIDs, neuropathic medications and painkillers, then supplements. Apart from that, we put them on a physiotherapy regime, initially modalities and then exercises. And then before this step, as I said, we do an X-ray. So we image the patient. So at least we are very sure that there is no fracture. And then we try the, conservative management. If conservative management fails, do an MRI, look for where exactly the nerve is being pinched, how severe is the cervical disc disease, and plan an intervention based on the symptoms and based on the MRI findings. And it is always better to go by symptoms and MRI. So both together. Don't treat the MRI. It is more of treating the symptoms. So sometimes the MRI shows, multiple level disc bulges and nerve compression, but patient has only pain in one particular level, like only C6, C7, or only in the C5 radiculopathy or C6 radiculopathy. Very commonly we see. So only that. So if you're putting, so usually cervical epidural, when we are doing, it is more the interlaminar approach. So it pretty much covers most of the segments. So, but one thing I forgot to mention is, so what I do is sometimes when I'm doing a cervical epidural, if the patient is having symptoms, as we know that more when there's a cervical disc disease, patients usually either some patients have unilateral pain, some patients have bilateral, so the neck pain, and so most often it is only on the one side. So it is, so what I do is if the pain is more on the right side, so I make sure the drug spread, the contrast spread and the drug spread is more towards the right and more concentrated on the right, so it works better. Then, and apart from cervical epidural, so that is the interventions part of view. So next, coming to the end of presentation, just a few tips to maintain spine health. So maintaining good posture. So I always advise my patients to maintain good posture, your neutral position while driving, while using a phone. Nowadays, because of the usage of smartphones, there's a lot of cervical disc issues, severe disc disease that we see, which patients are unaware of. And always use a proper chair and a table able, as I said before in my previous slides, how you're supposed to maintain your posture while using or while working on the computer. And then a regular exercise regime goes a long way. Neck stretch and strengthening exercises, and always seek medical help when you have radiculopathy or you have a lot of tingling and numbness, because compressive myelopathy can be dangerous. So thank you everyone for giving me this opportunity, MedPiper and JournoMed. So thank you. Yes, so we'll probably, oh yes, there are two more things which I forgot, sorry. So this is just an image to show you how your, spine position, or your, as I said, in the sagittal plane, the lordosis, the kyphosis, how it is. So as you can see, this is what happens in the standing position when you're slouching, especially people who are tall, they have a habit of slouching. So this is what happens to us, and over a long period of time, it, stresses your cervical disc, and then it causes problems. So this is how this is a neutral position while standing. So kindly maintain this. Then one interesting thing which I find, I wanted to talk about this. So text neck syndrome is the one thing which is common these days. I'm sure pretty much, I think most of us have it. So it is the stress on the spine caused by the weight of the head. So your head is really heavy. It is not as light. So your brain alone weighs like around 1,500 grams. And so what happens is, when you can see this picture, so how with every degree or every 10 degrees that you bend forward to look at your phone, you're slouching, it puts more stress on your cervical joints, cervical spine, and it causes so many symptoms. Actually, it is a spectrum of symptoms. Initially, it is only headaches. So most often we say, okay, we have a headache. It could be migraine, and it could be a cluster headache or a stress headache, but we should never miss out that it can also be because of using smartphones for a long time in one particular position, in a flex, your neck is flexed, so there can be muscle damage, there can be disc herniation. So better to keep this in mind. Text neck syndrome, a very common one these days. Yes, so thank you everyone. Thank you. So going on to Soumya. Yeah.
Thank you, doctor.
Yeah, we'll move on to the question session.
Yes, indeed, great session. We have a couple of doubts with reference to the pain management and everything. I'm just going to read one by one.
Yes, sure.
Okay, so the first question is, how common cervical disc problem in male or female?
If you see the male and female ratio, actually the female ratio of cervical disc problem is much higher. So in a lot of studies, if you see, the female preponderance is more actually because of posture related issues only. And male, yes, see, nowadays it's like occupational hazard. If you see, it is both male and female wise, it is the same, because anatomically the spine is the same for both males and females. So female preponderance more because maybe, a lot of activities, related to their posture. It is all posture related only, nothing otherwise.
Okay, doctor. So there is one question from Danya Chandrasekhar. She's like, initially I had disc pain L4 and L5. For that, I took Varma treatment for 10 weeks before 5 years now.
Okay.
After that, I'm suffering from cervical pain C4, C5. I have problem. I was undergoing. Okay, it's a very long question. Undergoing physio at that point, I was okay. Now again, I have right hand swelling and severe cervical pain too. Suggest me your opinion.
Okay, so this is one thing which I forgot to address. So what happens is, a lot of times, no, okay, I mean, I think even we would have done that in the earlier days. When we have pain, we think, okay, we'll go to a physiotherapist and get a physio session and come and it's going to be all right. So that is not the case these days. Very often we see, patients just keep getting, whenever they get pain, they get a physiotherapy session done, and, it goes away. And then they come back with the same problem because the problem is not rectified. So coming to her problem, so I probably need to examine. And apart from that, the cervical also needs to be addressed. The lumbar also needs to be addressed. But if the lumbar is not causing any pain, then might as well just leave it and continue the back stretch and strengthening exercises. Coming to the cervical problem, she would definitely need further evaluation, because if she has radiculopathy, as she says, pain, tingling, and numbness, if those symptoms are there, definitely needs evaluation. And as I said, going by how we manage these kind of patients. So we do some imaging, we put them on some, medicines. And then if medicines are still, if your pain is still persisting, then we might have to do an intervention.
Thank you, doctor. So I have next question from Dr. Krishna Prasad. Hi, it's an informative talk. I have a question. Steroids used in chronic pain during COVID. Steroid causes immunosuppression, also the COVID. So, any guidelines for steroids in this situation?
Steroids in this situation, sir, it's actually a very good question. So coming on to it, if the steroid is given if we are giving an IV steroid that is inside, for the layman, for people who are non-medicos here, so steroid given intravenously, basically inside your blood vessels. So those steroids have a much more systemic effect. We don't have standard fixed guidelines for pain procedure, steroid usage during pain procedure, even though we have that, we have a standard fixed dose, which is, we have 2 to 3 milligrams per kg of methylprednisolone for a year. So in a year, you can receive only so much. So one more thing is the steroids which I give in the, which is inside, which is not a systemic steroid basically. So it is more of in the place where the nerve is getting compressed, an epidural steroid. So the absorption in that particular region, it is not as high as the systemic which we are giving during COVID. So as we see, even COVID patients, the treatment protocol is on, we give them steroids to treat severe forms of COVID. So this small amount of steroid which we give epidurally is not going to, have a significant impact on the immunosuppressant aspect as such, unless it is given intravascularly. Intravascular is very, very minimal when it comes to giving a steroid epidurally.
Thank you, doctor. So moving on to next question from Dr. Sundaramurthy. How safe to use cervical collar for cervical disc problems?
Yes, thank you for the question, sir. What I suggest, the thing is, what happens is, coming to this, as you might have seen, just going to the lumbar aspect also, a lot of times, we advise patients to use a lumbar support, or without even advice, okay, they feel they have back pain and they start putting, these lumbar corsets and things. So what happens, we need to really understand this aspect of using this lumbar support and the neck support and all these things called when you keep using. So I have seen patients who use this lumbar support and neck collars for a long time, for years together, from morning till evening, they just use it. It causes, your abdominal muscles and everything are weakened, when you just put this corset and fully bind it. So what I generally do, it is better, it is not advisable as such. I don't advise my patients to use a lumbar. I do tell them only to use while travel, because the jerky movements, especially in patients with a lumbar disc or a cervical disc issue, they can have, it is better to give them that support while they are traveling, but otherwise it is better not to use it and strengthen their muscles instead, because this is only going to cause weakening of the muscles, abdominal muscles and all, when you keep wearing a corset. So generally it is not advisable. It is better not to. For a small amount of period, if you are having severe pain and things, okay, or if you have a fracture, otherwise I think it is not necessary.
Thank you, doctor. So moving to the next question, any artificial cervical disc available for replacement surgery?
Sorry?
Any artificial cervical disc available for replacement surgery?
So far, there is no replacement of disc which people have found out. There is only removal of the disc. So we have something called endoscopic spine surgery, but which is definitely, so far, I don't think they want to attempt it on, your cervical spine. So lumbar spine, we have discectomy. That is, you just remove off the disc. Otherwise, it's usually, the cervical, where there's a procedure called ACTF, where they put a plate and a screw, and then, keep the disc in place. That is, for severe cases, those surgeries are done. And for lumbar, there is pedicle screw fixation and all those things. And one more thing which we pain physicians do is the endoscopic spine surgery, same like how you have other endoscopic keyhole surgeries, no? So whichever disc is causing trouble, we just go endoscopically and remove that disc. So as I said, so these are the only procedures. There's no replacement of the disc as such.
Thank you, doctor. Moving to next question, it's from Anusha. She's asking what basic postures can we use while using the phone or the computer?
While using the phone or the computer, I think I have put a picture also, right? So I know it could be very difficult for anybody to use use phone. So it has to be like this. If you can see me, it has to be at the same eye level. That is when your cervical spine is maintained in a neutral position. So that is how you're supposed to maintain any time when you're driving. Driving also a lot of people do this, or they just go back. This is very common. Even I drive like this. So it is very hazardous to your spine. It can cause a lot of the disc issues in future. So always maintain a neutral position, like in my previous slide. How no this can you see the neck in this? Your neck is supposed to be in this position always, whether you're using a phone and especially using phone at night when you're lying down. That can be very dangerous to your cervical disc actually.
Thank you, doctor. Moving to the next question. It's from Dr. Anusudha. As a maxillofacial surgeon, there is occupational hazard of frequent trapezius muscle strain along with pain in left arm due to posture and load bearing. How to differentiate this from cervical neck pain? Is TENS useful in case of trapezius muscle spasm?
Yes, ma'am. So it pretty much looks like she's been having a cervical strain for a long time because of yes, it is occupational. Most of the doctors suffer from this because of a posture, especially surgeons who operate with their neck in this flexed position most of the time, because obviously we cannot stand like this and operate. So I think you will definitely need further evaluation, doctor, because you're having all the symptoms which fit into a cervical disc actually. So as I said, no, the trapezius spasm which you're talking about, everybody thinks it is because of so just the muscle having a spasm, and there can be some other cause, but it is not. It could be because of a cervical disc which is causing the trapezius spasm, and which is causing the pain radiating down your arm. It is better to get consultation with a physician or a pain physician or orthopedician and get it sorted, and maybe start on medications. Physiotherapy, as I said, IFT, yes, definitely helps for cervical radiculopathy, but one problem is it does not cure it. So temporary measure, unless your disc which is compressing the nerve is sorted, if the pain is going to be there, IFT helps. IFT will because it is more like neuromodulation. So when you do neuromodulation, definitely the nerve is stimulated, and then the pain subsides, and for 2-3 days you have 2-3 sessions. Actually, even after one session of IFT, there is a lot of difference, and you have some 30 to 40 percentage of pain relief. But then it is temporary. You have to, the disc is the problem there, and the pinched nerve is the problem which needs to be sorted. And posture correction, I think it must be difficult for an orofacial surgeon. I mean, they have to bend down and do it. So yes.
Doctor, do we have time to take more questions or?
Yes, I mean, if it's
No
okay.
problem. Yeah, sure. One moment. So, okay. So next question is from Dr. Atul Bhargav. When to use hot compression and when to use cold compression?
Yes, this hot compression, cold compression, when we see, when it is more like a muscle related, I think when it is more for the joints and all, no. So I think in that case, it is like the cold compresses work. But what I've seen is it different. I mean, it is different in patients. Like although we have a certain concept, some patients get relief from. But usually for cervical disc patients, what I've seen is like with the muscle spasm and everything, looks like the cold compresses work better. That's what I found out. They say that they get good relief, and it reduces pain, basically cold compresses. So in those conditions, when there's inflammation and everything, I think that time the hot compresses works.
Thank you, doctor. Moving to next question. What is the ideal way to overcome whiplash injury?
Whiplash injury, yes, I think I just missed it. So I think an orthopedician would be better, will be able to answer this better rather than a pain physician, because whiplash injuries, I always refer to them because they are the experts at it, not me. Yes.
Thank you, doctor. I'm just taking out the last question from Venkatesh Ratnavel. He's asking any treatment for supraspinatus tendonitis.
Yes, so supraspinatus tendonitis is another. Actually, some patients who come with shoulder pain, apart from a neck pain which is radiating to shoulder, they also have supraspinatus tendonitis. Maybe it's the supraspinatus tendonitis pain which is just radiating there. So supraspinatus tendonitis, yes, sir, it is treatable. So now, if you see, first is we can put them on medications, and then we can put them on platelet-rich plasma therapy. Actually, off late I've been using PRP for tendonitis, and it works wonders. Of course, it takes a long time. It is not an instant, immediate relief. Like if I inject a steroid and a local anesthetic, the relief is more immediate and within few days. Whereas if it is platelet-rich plasma, it definitely takes more than 2 to 3 weeks actually for the effect to start in. But beautiful results for supraspinatus tendonitis, or any form of tendonitis. Actually, I do an ultrasound guided supraspinatus tendonitis. I do a PRP ultrasound guided, so it works really good.
Thank you, doctor. I think we have taken all the questions. But in case if any of you have any doubts or inputs, or if you want to meet Dr. Sherin, she is pretty much in Chennai. Her clinic is pretty much in OMR, so maybe you can contact her. And so I'm just doing a closing remarks right now. Thank you everyone for joining us today for an amazing session on pain management, cervical disc issues, and we spoke about lifestyle changes. We spoke about posture corrections, and being in COVID situation, we all are in a work from home condition. And yes, there are certain steps that we can take now to make it right. And we would like to thank Dr. Sherin, for spending her, time and detailing each and every aspects of cervical disc management and also the pain aspects as well. Thank you, doctor, and thank you, everyone.